So, good evening, everyone. On behalf of the Bombay Spine Society, we would like to welcome all the spine enthusiasts and the spine fellows for our upcoming session on cervical spondylotic myelopathy. The faculty is Dr. Sandeep Sonone, sir, Dr. Nikhil Arbatti, sir, and myself. And we have two dashing fellows who would be presenting a couple of cases and the journal club for this. So without further ado, I would like to welcome all the senior faculty as well as the juniors and my colleagues to this session. And with that, I would also have Dr. Sandeep sir say a few words before we go ahead.
Yeah, thank you, Akhil. Thanks a lot. So without wasting too much time, I think we should move on with this particular session, which is a very important topic. There's a lot of gray zones in this, in this particular topic. Difficult to understand how to manage, what is the etiopathogenesis, so many conditions contributing to it. So I think a lot to discuss, and I think we should get moving.
All right, sir. So with that, I'll start with the first presentation, which is by Dr. It's a pre-recorded talk by Dr. Sandeep Sonone, sir. Is it audible to everybody?
We can't see the screen, Akhil.
We can't see you or hear.
Okay. Let me do that again, please.
Yeah.
Is it audible now and seen?
No, we can't see.
Okay. Something is not right. Just a sec. What about now?
The talk is still not seen, Akhil. You can sort it out later. I guess you go on to the next aspect.
Yeah, I think we can have it later then. We can have it later, somewhere in between.
Yeah. Okay, so then I would invite the fellow Dr. Amaya to start with his journal club and then start with the case presentation after that. So can I have Dr. Amaya to share his screen, please?
Yes, sir. So shall I start?
Yes, please, go ahead.
Good evening all. This is Dr. Abhay Nene. I'll be presenting a journal presentation on cervical spondylotic myelopathy. I'll be presenting two journals, which are review articles from Asian Spine Journal. The first one is Degenerative Cervical Myelopathy, pathophysiology and current treatment strategies. Second one is from AO Spine, current diagnosis and management of cervical spondylotic myelopathy. Now, what is definition of cervical spondylotic myelopathy? It is a progressive degenerative disease causing chronic compression or ischemia of the spinal cord in the cervical spine, which leads to clinical syndrome known as cervical myelopathy. Is degenerative cervical myelopathy equivalent to cervical spondylotic myelopathy? So Nouri et al. Proposed an umbrella term called as degenerative cervical myelopathy, which encompasses ligamentous hypertrophy, calcification, or ossification in addition to the classical entity cervical spondylotic myelopathy, which includes spondylosis, intervertebral disc herniation, and facetal arthropathy. Now, coming to the pathophysiology, there are two factors: static factors and dynamic factors. Static factors include the congenital narrow canal and spondylosis, while dynamic factors include the instability. There was this paper published which emphasized on the importance of the sagittal diameters of the cervical spinal canal in relation to the spondylosis and myelopathy. So this was done at the mid-cervical spinal level. Sagittal diameter was checked, and they found that the normal sagittal diameter of spinal canal was 17 to 18 mm. The relative stenosis was said to be at below 13 mm, and absolute stenosis was below 10 mm. To correct the magnification error and the limitations which were present in the previous paper, Pavlov et al. Published this paper of cervical spinal stenosis, where he calculated the spinal canal to vertebral body ratio to give more accurate results. The normal value was considered to be the 1, and stenosis was to be considered below 0.82. Now, there are many causes. The first most common cause is cervical spondylosis, which constitutes about the 55% cases of the degenerative cervical myelopathy, which is commonly seen as decrease in disc height, osteophyte formation at the vertebral end plates, and hypertrophy in the facet joints. Other common causes include the facetal cyst, ossification of posterior longitudinal ligament, and ossification of ligamentum flavum. Other dynamic factors include the flexion extension, which causes the buckling of ligamentum flavum. Myelopathy can occur when the dynamic sagittal diameter is said to be less than 11 mm. Instability causes include the translated displacement of 3.5 mm as well as angulation of more than 11 degrees. Now, coming to the pathophysiology, she and Pryor in their study found out that the spinal cord elongation increases the temporary membrane permeability, which in turn causes a transient electrolyte imbalance and conduction loss in myelinate axons. Moreover, irreversible conduction loss resulted in more severe anatomical membrane damage, which in turn initiated the biochemical cascade, which lead to increased concentration of glutamate and further cell damage, which led to the apoptotic cell death. And the corticospinal tract is involved more. Now, the clinical manifestations include it is more common in 40 or more years of age. It is more common in men as compared to females. It usually presents with hand numbness, loss of fine motor function, global non-dermatomal paresthesia, impaired gait, lower extremity weakness, and incontinence or urgency in urination or defecation. The physical examination includes increased upper and lower extremity reflexes, lower extremity clonus, spasticity, and some signs like Hoffman's Babinski finger escape sign. Grip and release test is done, which is seen. Lermit sign is seen, and loss of sensation in the lower limbs. Now, differential diagnosis to the degenerative cervical myelopathy includes most commonly amyotrophic lateral sclerosis, which can be differentiated from DCM by via tongue fasciculations on physical examination and denervation pattern seen on electromyography. Other DDs include multiple sclerosis, normal pressure hydrocephalus, Parkinsonism, B12 deficiency, syringomyelia, and tumors. Coming to the radiology, the most common pattern seen is end plate sclerosis, disc space narrowing, and osteophyte formation. Also, there may be presence of bony bar on the retrovertebral space or retro disc space, which may be ossification of posterior longitudinal ligament, or there may be foraminal stenosis, which may be seen to the uncinate process hypertrophy. Another important use of X-ray is to know the lordotic as well as kyphotic angles, which can be seen by drawing a line on the posterior border of C2 as well as C1 and measuring the angle between them. MRI can also reveal the extent of pathological changes in the intervertebral disc and hypertrophy and buckling of ligamentum flavum, amount of decrease in the spinal canal diameter, and the severity of spinal cord compression. Now, there was another study which said that does the type of T2 weighted hyperintensity influences the surgical outcome in patients with cervical spondylotic myelopathy? So it concluded that in MRIs with multi-segmented increased signal intensity as well as sharp T2 increased signal intensity, they had a poor prognosis, while regression in T2 weighted hyperintensity were associated with a better prognosis. In patients with contraindication to MRI, CT could be an effective diagnostic option. EMG and NCV studies are also useful. Now, the natural history of disease is such that 75% of patients experience episodic deterioration of neurological status. 20% of patients had a slowly progressive neurological status, while 5% of patients had a rapid onset of symptoms of myelopathy. Now, coming to the treatment, there is generally no role of conservative management in a long term. The goal is to relieve the mechanical compression, extend the spinal canal. In the study conducted by AO Spine North America, it was seen that there was significant improvement in MJOA, Neuric score, and neck disability index. Now, factors that decide the approach. It mainly includes the disease, etiology, cervical alignment, and number of segments involved. If we roughly see the approach, it mostly includes, if we see anterior approach is mainly done in pathology lying anteriorly, disc herniation, and spondylosis. Posteriorly is done in mostly multi-segment compression, and combined approach was seen in rigid kyphosis, OPLL having multi-segmental compression, or in complicated cases. There was this chart published in this article of AO Spine, which gave a rough estimation of the approach to be taken in certain pathologies. Like if there is a fixed kyphosis, anterior approach is to be taken. If it is flexible, anterior or posterior approach with fusion may be taken. If it is neutral lordotic, posterior with laminoplasty was preferred more than anterior in approach. If number of levels involved are more than 3, then posterior approach was more preferred as compared to anterior. Less than 2, then anterior approach was more recommended in posterior approach. In elderly patients, posterior approach was preferred, while in healthier young, anterior approach was recommended. Whereas if pre-op pain levels were high, so anterior posterior approach with fusion was recommended, while laminoplasty or anterior fusion approach was recommended in lower pain levels. If there was instability, anterior posterior fusion was recommended. If there was no instability, posterior simple laminoplasty or anterior fusion procedures were recommended. This is a simplified algorithm chart for the treatment option. If 1 or 2 levels of compression is seen with rigid kyphosis or less than 10 degree rigid kyphosis, anterior approach was recommended, which may be in the form of ACDF or corpectomy or a hybrid approach. If more than 3 levels of compression was seen, combined in a more than 10 degree rigid kyphosis, combined anterior posterior approach was recommended, where anterior approach was done to correct kyphosis and decompress, whereas posterior approach was done to decompress. Whereas in less than 10 degree rigid kyphosis, posterior alone approach was recommended, which may be in the form of laminoplasty or laminectomy and fusion. So the conclusion is degenerative cervical myelopathy presents with various degrees of symptoms and signs. If compression of the spinal cord is confirmed on imaging tests in a patient with chronic cervical myelopathy, appropriate surgical treatment will not only suppress the disease progression, but also improve the quality of life. The choice of surgical treatment should be based on the patient's general condition, extent of compression, presence of concomitant cervical radiculopathy, and cervical alignment. Thank you.
All right, Dr. Ramaya, thank you for that Journal Club presentation. Does anybody have a question based on this for Dr. Ramaya or any discussion?
So, Amaya, just one question, couple
Yes,
of
sir.
questions actually. Just to clear the basics a bit, what do you understand when you say pathophysiology or pathogenesis of myelopathy? How does it actually progress? I mean, where does it start? What's the offending structure? Is it how does it progress from being a anterior sort of pathology to a global pathology? So, what's your understanding on that?
Yes, sir. So it is a long-term degenerative process. Just the difference being in very rare cases, like in less than 5%, it is rapidly progressing. Otherwise, in majority of cases, it's a chronic degenerative process, where the pathology is mostly degenerative, which are the age-related changes, mostly anteriorly due to disc or ossification of posterior longitudinal ligament, or posteriorly by enfolding of or buckling of ligamentum flavum, or it may be seen due to instability, where micromotion of in between the vertebral elements induces osteophyte formation and leads to compression of nerve, where the chronic compression may lead to the changes in the cord.
So it's basically the disc which is always the offending structure. So there's loss of disc height, which puts more pressure on the facets. It also causes osteophyte formation. The end plate changes, the vertebral body changes, and that collectively, the hypertrophy of the osteophytes behind the body. So that decreases the canal, and that also causes uncovertebral joint hypertrophy. So there's compression all around. So invariably, when we say a degenerative cervical myelopathy, like cervical spondylotic myelopathy is probably a old term now. It's a degenerative cervical myelopathy. It is basically global compression, wherein the disc is always the offending structure, and this is totally different from other causes of myelopathy like an OPLL, right?
Yes, sir.
Yeah. So what's your understanding when they say that in a rigid kyphosis you need to go in anteriorly? What's the cause of that?
Uh,
What's the
because
rationale?
because post laminectomy, kyphosis may happen. There is tendency for kyphosis to happen, and loss of cervical lordosis may happen, which may lead to kyphosis. So just to not add up to the additional to the rigid kyphosis, generally either anterior or anterior plus posterior approach is taken.
Any other fellow wants to add to this? I mean, Akhil, you can just delegate somebody else to talk on this, answer this. Any other views on this particular thing?
Can I have Dr. Raj Sakrekar? Can you comment on this, please?
So he said that because posterior procedures can cause increase in the kyphosis, they have recommended anterior procedure. Is that so? Any other reason for that?
Yes, sir. Sir, first thing, if there are different angles they calculated. If the angle between the C2 and C7 is found to be more than 13 degrees, means which is more of kyphosis, then it can lead to the post-laminectomy kyphosis. Again, leading to the more of compression leading to the kyphosis. So they have advised to fix anteriorly, which will eventually help to maintain the lordosis. If it's the giving rise to uh, kyphosis, they think of adding the anterior with posterior in such scenarios, sir, so that the mechanical construction will be good and there will be maintenance of the lordosis.
No, I think, see, when we predict post-laminectomy kyphosis, that is something which is not very predictable, right? So one of the reason why they could be suggesting a rigid kyphosis and anterior surgery in that case is because if you do a posterior procedure, the cord, even though it falls back, if there's kyphosis, it won't fall back, right? There would be
Yes, sir.
still an area of focal compression anteriorly. So the whole rationale behind a posterior procedure is that you decompress the cord, which is an indirect decompression. You're leaving the
Yes, sir.
anterior compression behind and allowing the cord to fall back, right? So you're basically depending on the lordosis for you to give an indirect decompression, which doesn't happen in a kyphotic spine. So that's why they recommend anterior procedure in rigid kyphosis. One is to correct the kyphosis, and second is also to achieve a good direct anterior decompression.
Okay, sir. Is there also concern? I'm just a question. Is there also concern of C7 palsy considering posterior decompression? That's why they are also advising. No, no,
No,
sir.
see, yeah, anybody wants to answer that? So the question of C5 palsy is basically it's a complication of a posterior procedure, right? And the incidence is, it's not like it's 100%. It's almost in the range of 20 to 30%. Okay, and there are multiple series or multiple papers which give different incidence. it is many a times underdiagnosed. So that's a different issue altogether. The primary aim is always about cord decompression and allowing the cord to fall back, you know. So that complications will come later on. First is achieving your goal.
Okay, thanks.
One more point I would like to mention. So in etiopathogenesis, apart from the direct mechanical pressure, there is also some evidence on the ischemic insult that is actually taking place. And at the cellular level, it can lead to apoptosis of the oligodendrocytes. So further research based on the medications are actually based on trying to reverse the vascular insult. So just a point that we should also consider, apart from the direct compression, also the ischemic insult going out at the level of at the cellular level.
Right. Ameya, and one more thing you mentioned was that, you said that in one of the slides, I mean, this is just what you have concluded from the paper. They have said there's no role of conservative management. So when you say that this, almost 20% of the patients have a very gradual course and they're just waiting for one particular episode to hit them so that they can deteriorate. How do you see this when they say that there's no role of conservative management?
Sir, no role of conservative management in moderate to severe cases. I failed to write there.
Right. So in mild cases, there's definitely a period. I mean, I'm not very sure what conservative management really works in cervical myelopathy, but whatever it is, it's whether it's a collar or whether it is, sort of lifestyle modification or educating the patient regarding his condition because he's sitting on a time bomb. But whatever, I mean, it does help in early cases where you just diagnose it and the patient is not really functionally disabled.
Yes, sir. So shall I go ahead with the case?
Okay, yes, please go ahead with the cases.
So this is the first case scenario where there was a 60-year-old male who had complained of imbalance during walking since 2 months, which got suddenly aggravated over the last 15 days. Paresthesia was there in both lower limbs from hip to toes, right equivalent to left. There was no pain in upper limb or lower limbs. On examination, Hoffman's was positive. There was hyperreflexia. Babinski was upgoing. Spasticity was seen, and the neurology in gallbladder was normal. So this was the pre-op picture. There was compression seen in a sagittal T2 image as well as axial T2 image. We can see there was a compression seen at C5, C6 level. And on axial image, we can see there is compression, central compression and more towards the left. On X-rays, no instability was observed in flexion extension views. So the question is whether we go for the conservative management or operative approach should be anterior or posterior, and if anterior posterior approach is taken, then which surgery is to be done.
Dr. Abhay, can you put the MRI slides, please, once again?
Yes.
So Amay, now what do you actually understand from this particular picture? What does the clinical picture tell you? If you go back one slide and show us the clinical, so what does this tell you?
That the patient has imbalance during walking, and
so what does that suggest?
There are myelopathy features.
Yeah, but which part of the cord is getting compressed?
Corticospinal tract is involved.
Corticospinal? Is it anterior or posterior cord compression?
Anterior cord compression.
Anybody else, Subhanshu? Any other fellow that anybody wants to differ on this?
Imbalance is mostly suggestive of posterior column tract injury, and because of the proprioception sensation lost during the insult.
Right. So it's basically posterior compression, right? If you go to the MRI, you just put up the MRI. So now what do you make out of this, of the MRI? So you want to operate this patient. So whenever you are thinking of management, there are few things that you need to decide on, right? Whether you want to operate whether you want to conserve, if it is surgery, what sort of surgery is anterior, posterior, if it is anterior, what surgery, if it is posterior, what surgery, what is the prognosis that you are expecting in this case, and finally, what is going to be the functional outcome of the surgery. So in all these factors, what are the things that you are thinking along, on this MRI picture?
So the compression is mostly anterior. You cannot
Right.
appreciate much significant posterior compression.
Right.
And it is a single level with the lordosis maintained. So we would prefer to go by anterior approach.
What is the cause of this compression? Is it a disc? Are you sure it's a disc?
Yes, sir, it seems like a disc.
Oh, how can you be sure that it's a disc?
Sir, there is reduced discal height at C5, C6.
Anything else that can cause this compression? This sort of compression? Any ossification? OPLL?
OPLL may be there, but it doesn't seem like there is OPLL in this image.
Why?
Retrovertebral, there would have been like hypointense pattern, as well as on X-rays we would have.
Yeah, so OPLL cannot be diagnosed very easy on an X-ray, right? There are multiple types of OPLL, if you are aware of it.
Yes, sir.
So if it's a single level OPLL, which is sort of bridging the disc, you can never be sure. And if you look at the MRI, the axial scans, the one in the center, right, the second row, the one which is labeled beside that C5 or C3, C4, whatever it is, you see like a mushroom sort of an appearance, which is compressing the cord. So any other investigation which you would like to do in this case to rule out an OPLL?
CT scan, we can do CT scan to rule out OPLL.
Have you done a CT scan in this case?
No, sir.
Okay, fine.
So one more thing, Dr. Amay. Are you happy with only looking at T2 weighted images, or do you also want to consider T1 weighted images in cervical spine in the myelopathy patients? Any particular reason why or why not?
Shubhanshu?
The causes.
Shubhanshu, can you answer?
T1 images are generally seen to rule out any bone edema or infection or instability.
No, his question is pertaining to the cord, right? So
Yeah.
what he wants to ask is that, is it, because you said in your paper that T2 hyperintensity is a high risk, sort of, poor prognosis. Anything which is worse than that?
Myelomalacic changes, but that will be seen more in.
So if you have a T2 weighted changes, they are sort of, they could be reversible. But if you have changes on the T1 weighted image,
Correct.
then those are irreversible changes. That signifies a permanent cord sort of, affection. So that's one thing that he wanted to say. So if we need to have a look at the workup, then I would always get a CT scan done in this case, purely because the axial images, I'm not very sure that this is definitely a disc affection. I mean,
Yes.
You can still go ahead, because these are, you can study all those cuts and be sure about it. Okay. So suppose this was a OPLL case, how would it differ? How will your management differ? What are the different questions which come to your mind?
If there is retrovertebral pathology, it will be difficult to operate anteriorly. First of all, that would be a question.
Why? What's the difficulty?
Sir, cord could not be manipulated.
No, you don't manipulate the cord.
I mean,
you don't manipulate the cord.
Yeah, it will require more surgical steps.
You can go ahead and do a corpectomy. The question is whether you can get a good amount of decompression in these cases. So if it's only a pure disc affection, you can get a good decompression. If it is no ossification, you can still get a good decompression, even if it is retrovertebral, by doing a corpectomy. That's another debate. Okay, but if it is ossification, you can still go in and get an anterior decompression, provided you can go all around the ossification mass and get the compression out. Okay, and there are different techniques for doing it that we can discuss later on. Right. So in the workup, yeah, you need to study the MRI in a much better way. You need a CT scan to be sure that it is not an OPLL. Right. So what are the next questions which come to your mind?
Like what surgery is to be done? So after this, no, after it has been decided that but whether will you go anterior or posterior?
So what's your rationale for going anterior? What's your rationale for going posterior in this case?
Since it is less than 3 segments are involved, we can go anterior in this case, and we decided on what CT scan shows. If there is ossification OPLL seen, and if there is any retrovertebral pathology, we can go with corpectomy, or if it is a circumscribed lesion or just disc, then we can go ahead with ACDF.
Right. Right. Okay. Why not posterior even in this case? What's the disadvantage of a posterior surgery? There's single level compression. I would suppose I say that I would like to go posteriorly. So what's the disadvantage in that?
Sir, pathology cannot be addressed directly if we go posteriorly.
So whenever the compression is anterior, whenever possible, you need to directly attack the compression. Okay. So all the other procedures which have been described, especially the posterior ones, are sort of you're trying to balance between what is safe and what is practical. Okay. So if it's a single level compression, whenever you are doing a posterior procedure, you cannot do a posterior single level decompression because the posterior procedures rely on cord fallback or indirect decompression. If you're doing a single level decompression, the cord's not going to fall back. You're not going to get the neurological outcome out of that. And the other thing is that all the disadvantage of a posterior procedure apply, and that we can discuss later on.
Yes, sir.
Okay, so we can move ahead. Yeah.
The second
Dr.
case.
Amay.
Yes, sir.
Dr. Amay, just come. Okay. So before that, what exactly will you talk to the patient about this? Any specific counseling that you will do with regards to that? How much recovery can the patient expect? Based on that, what would be your counseling like with the patient for the first case?
Sir, if the pathology has been acute, I would counsel him that like there will be more probability of recovery as compared to a chronic, if there had been a chronic patient. So I will expect an early recovery. Second would be I won't promise him much earlier return of normalcy in bilateral lower limbs, like regarding paresthesia. And
What are the reasons? I mean, what are your prognostic factors for neurological recovery in this particular case? Because the patient is, if you tell the patient this, he's never going to get operated, right? So as a surgeon, you must be having some factors in your mind that tell you, fine, this patient will do well if I operate early.
like if there's a soft disc and acute pathology, I can expect an early recovery. And
Acute in the sense is this patient has a myelopathy and he lands up with a whiplash. So is it what you mean?
no, sir.
So what do you mean by an acute pathology? So basically you mean duration of symptoms is quite recent, right? It's
Yes,
not
sir.
like an acute inciting event which has triggered off the whole thing, because there are patients who are borderline, the so-called mild ones, who are very borderline, and they have a inciting event like a whiplash injury, sudden acceleration deceleration injury, and that can cause kinking of the cord and sudden cord edema. Okay, so that's like a traumatic fracture which happens in a spondylotic spine. In that case, the recovery is very poor because there are cord changes which are central. Okay, this generalized edema. So suppose this patient had radicular symptoms and myelopathy symptoms. So how will you counsel for each?
I would expect an early recovery for the radicular symptoms. The pain will go away faster as compared to the other symptoms. Gait instability will come later as well as the paresthesia part.
Any particular reason why you expect radicular symptoms to go away faster than myelopathy symptoms?
Because the pathology which is causing the insulting factor which is causing the pathology compressing the nerve, we will remove it in surgically, so the nerve will be decompressed and that will relieve the patient of pain.
Right. So basically, the compression on the nerve is like a lower motor neuron lesion, right? So that's why the recovery the recovery will be faster, especially the pain component. Because if you see all these patients, in advanced stages they have these hand changes and wasting of the hypothenar muscles. But early in the course of the disease, if they land up with a gait instability, very rarely they would have significant hand disability. That might come in late during the course of the disease, so they respond much better. Right, we move on, Akhil.
Yes, go ahead, please, doctor. So what was done for this patient?
So ACDF was done.
Okay. Okay, go ahead, please.
Can I add something? Can I add something?
Yeah, please, Ayush,
Yes,
please.
yes,
Yeah,
yes,
Ayush,
Dr. Ayush, please go ahead.
So one more thing which could have helped with the to predicting the recovery is the preoperative MJO scores. So that also tells you how the recovery will be. So if your scores are very low, especially less than 12, the recovery is likely to be less compared to scores which are in moderate range. So there is a so MJO score, preoperative MJO scores, and your duration of symptoms. These are the two most important factors, and the preoperative neurology. These are three most important factors which might help you determine the recovery later on. Just that. That's it.
Okay, sir. This is second case. It was 63-year-old male who had complained of mild neck pain since 2 years. He had bilateral lower limb burning sensation, and he had gait imbalance developed over last 3 months. There was clumsiness in both hands with difficulty in doing fine work like buttoning shirts or writing. The MGOS score was 14. The Hoffman sign was positive. Hyperreflexia was seen, and neurology and bowel bladder were normal. So here's the MRI picture.
Can you please describe the MRI for us, please?
Yeah. So this is T2 weighted image, sagittal view, and there is a hypointense lesion on the posterior aspect of C5 extending up to C6. Similarly, for this patient, CT scan was done on sagittal image. There was ossification seen along the posterior aspect of C5 and C6. On axial image also, there was ossification seen on the anterior aspect of cord.
So Amay, can you just go back to the history? So how do you explain the bilateral lower limb burning sensation?
So burning sensation, he had paresthesia specifically. He complained of burning sensation in the parietal fluid. Now that we can differentiate as a myelopathic feature or as a peripheral neuropathy.
Right. So anything else that you want to do in this case when you see how many of our myelopathy patients actually complain of lower limb burning sensation? What is the earliest symptomatology that they come to you with? Most of these patients, when they walk in and you suspect a cervical myelopathy, what is the most obvious thing where you can diagnose the moment they come in front of you, or maybe suspect when they come in front of you?
So gait pattern?
It is always the gait, right? So most of these patients come with, those those neuric early stages, sort of grade 2 or grade 1 or grade 2 neuric stages, right? So how many of the times do these patients complain of burning sensation? So what does it make you think what else could be the cause of this burning sensation? Anything else that you want to rule out?
Peripheral neuropathy should always be the
Fine.
root
So
cause.
maybe the cause diabetes, right? Because most of these patients are early, so you need to rule out other causes of peripheral neuropathy like diabetes. Anything else?
Whole spine sequence to see
Sorry?
the lumbar. The whole spine sequence to see the lumbar involvement.
Right. Why?
Tandem.
Right. Tandem stenosis, right? So almost 1 in 4, that's 25% incidence of tandem stenosis. And especially when you see, when you already seen the MRI, if you see the MRI, it looks like a sort of a tight congenital stenosis. You see this MRI? Again, we would definitely be asking you all the ratios and all. But this goes more in favor of a congenital narrow canal, wherein tandem stenosis is very common. So when you think of the symptomatology where the patient is coming, you always need to look out for all these things. What else could be the reason? The patient has come to you for burning, sensation in his feet, right? So you need to find out the exact cause. You can operate on the cervical spine and leave the lumbar spine, and he's not going to get relief of his symptomatology, right?
Yes, sir.
Yeah.
Also, sorry, sir. So, Dr. Amay, would you like to also comment on the alignment of the spine while we are here?
Yes, sir. The
Correct.
cervical
So,
spine is straight, but there is local kyphosis present at C6-7 level.
yeah. So, I mean, so definitely the lordosis is gone even on an MRI, correct, which is in a supine position. So we have to be very careful about this because the alignment has gone for a toss, and X-rays would definitely be helpful in order to calculate the angles in this case.
So can you go back to the X-rays, Amay?
Uh,
So one thing is that never comment on the alignment on the MRI. You know why? Because the MRI is done in the lying down position. Okay, so you need a standing X-ray to actually comment on the alignment anywhere in the spine. So you have the X-ray, and the X-ray should always come before the MRI and the CT scan.
Sir, X-ray I'm not able to see. It was there in PPT, but
Okay, fine. The CT is fine. Yeah. So now what do you make out of this on the X-ray and the CT scan?
sir, there is OPLL, ossification of posterior longitudinal ligament at C5-6 region.
Okay. What other information that you want to derive on the CT scan? Apart from the bony abnormalities or bony structural changes. So one is, you said OPLL. Anything else?
So there is anterior, like dish also, anterior flowing ossification is also seen.
Fine. Then
K line is to be drawn to.
that is later on. But the initial picture, what do you want to see? You want to see how much is the disc height, right?
Yes,
Whether the OPL is there along with the disc, or whether the disc which is settled and giving rise to calcification mimicking the OPLL. And why is it important to rule out a disc which is calcified and an OPLL?
Sorry, sir.
Why is it important to differentiate a calcified disc with kyphosis from an OPLL mass? Both will give almost a similar picture, right? So how do you make out an OPLL from a calcified disc, and why is it important? Shubhanshu?
Sir, OPLL is more of a progressive condition. It will affect the upward vertebra also, while the calcification will be a localized condition and can be dealt with surgically with only discectomy or corpectomy.
From the progression point of view, uh, he mentioned that even cervical myelopathy progresses, right? So the
Yes, sir.
management will differ totally, because in OPLL, you probably might not want to go in anterior and try to study the OPLL mass further.
Yes,
As
sir.
I said, in OPLL, there are a lot of other issues like dural adhesions, and you might not be able to get a good decompression. Whereas in a cervical disc ossification or calcification, that's not the case. There's always a layer between the calcified disc and the dura which you can get out. So that's why it's very important. The third thing is the alignment of the spine, right? Whether it is generalized kyphosis or there is focal kyphosis. Now, in this case, if you see there's a very small area of kyphosis. The rest of the spine which is above the C4 and below the C7 looks quite okay. It is a segmental kyphosis. So in that case, you would definitely prefer to do a small limited anterior decompression, which will spare the other levels.
Yes, sir.
If you go in posteriorly, you are sort of compromising on all the other levels. Anything else that you want to derive information on the CT scan? Axial views? Amay, do you have the axial views of the CT scan? Yeah. What information do you want to derive from this?
To see at what level the ossification is and whether it is at discal level or at the upper vertebral level.
Right. Then?
So the plan may differ according to that.
Agreed. Anything else? Why do these patients complaining of giddiness? You talk with any cervical spine patient, a myelopathy, they say sab chakkar aata hai, Why do they complain of giddiness? Any guesses? You need to rule out uncovertebral joint hypertrophy, which can cause compression or give rise to vertebrobasilar insufficiency, right? So if you turn this patient's neck on one side, they will frequently complain of giddiness. That is because the uncovertebral joints are hypertrophied and they press on the vertebral artery, and that causes these symptoms. And you need, in this case, it's an OPLL. So even in the OPLL, you want to see what is, if you plan to go in anteriorly, what is the procedure of choice? Whether you can get all along the OPLL mass and do a good decompression, or you might not be able to achieve it. In that case, you can go in posterior. Right?
Yes, sir.
Any other faculty wants to add anything? Ayush or Sameer or?
Just one thing, you can look for the double layer sign or the double ring sign in the CT scan, especially when you have a OPLL, because that could be something which can tell you if the OPL is stuck to the dura. There's some, you can read about it. There's something called double ring or double layer sign, and when you get that, you should be extra careful that the likelihood of the OPL being stuck to dura and just everything I think has been covered.
Right, we can move on, I think. Okay.
Go ahead, yes, doctor.
So can we ask him what's the procedure for choice in this case? How? What are you going to do in this particular case, and what is your rationale behind that thought process?
Sir, in this case,
just one sec. You know what has been done, right? Since you're presenting, so I would like to ask Subhanshu in this case, because we don't want a biased opinion. Subhanshu, what will you do in this case?
Sir, since there is a kyphosis in the cervical spine, the cord won't fall when we do posterior surgery. So I will go with the anterior one, removing 5-6 corpectomy and fusion.
So what is the pathology in this case?
Sir, 5-6 disc osteophyte complex with early OPLL.
Okay, so what are the difficulties that you expect when you go in anteriorly?
Sir, anteriorly, the calcified mass might stuck to the dura, and that will be difficult to remove it.
So in that case, what's your option?
Sir.
So if you see the CT scan in the middle row, the CT which is on the extreme corner, in the middle row on the side of MRI, you can see that mushroom shaped sort of bony outgrowth over there. So this is almost like a mushroom shaped OPLL, wherein the dura invaginates from either side of the OPLL mass or the calcified mass, and it's very difficult to separate that dura, and sometimes you can land up with a dural tears. So only if you can go all around and leave this OPLL mass behind, what is called as the anterior floating method, then only you should think of going in anteriorly. Okay. because otherwise it's always better to go in posteriorly. Now, in this case, I'm not able to actually judge whether it's a OPLL or not because I need to study the CT scan in a much better way. But yes, if it is not an OPLL, you can safely go in anteriorly.
Okay.
Any role for combined approach for this case? Anybody? Dr. Subhanshu, Dr. Amaya?
Sir, if pathology can be addressed anteriorly or posteriorly, so then why we would prefer to do combined approach?
Correct.
And
So the
have
question is,
overall instrumentation?
do you think you will be able to tackle the alignment as well as the pathology from one approach? What is the preferred approach if there is a congenital stenosis kind of a picture?
Laminectomy.
Posterior laminectomy.
Correct. And will we get adequate cord drifting posteriorly with a posterior approach in this case? Can you predict how much the cord will posteriorly drift? Have you thought about the K line for this, the modified K line on the MRI?
What's the K line? Amaya, what's the K line?
Sir, it is a line drawn along joining the midpoints of C2 and C7, and it is a line like drawn at the
C2
center
and
of
C7
spine.
what? C2 and C7 what?
Posterior border of C2 and C7 with the
No, I don't think that's the right answer.
lamina, like midpoint of spinal canal.
Right.
Yeah.
Drawn along the
Right.
midpoint of spinal canal. If it is exceeding posterior to midpoint, it is K plus, and if it is less than 50%, it is K minus.
Ulta. It's the other way around.
Okay.
It's the other way around, right? What's the rationale? Like Dr. Akhil asked a question, a combined approach. What's the rationale behind a combined approach?
To get the alignment, so restore lordosis if it is not rigid.
Anything else from the neurology point of view? So whenever you have a fixed kyphosis, right, the cord is tented over the OPLL or the kyphotic mass. So in that case, if you want to go in anteriorly, you are risking the cord to further injury. You do a posterior decompression, allow the cord some space behind, and then that is a sort of a partial decompression. Then you go in anteriorly and do a segmental decompression, wherein you can decompress the cord globally at that particular level. Also, you'll get a good chance to distract the anterior column, restore the lordosis, helping the cord fall back and aiding in the first procedure. Got me? So the
Yes.
first procedure is always to do a partial decompression. Second is to complete the decompression and reconstruct the column in lordosis, aiding in the first procedure. So that's the whole rationale of a combined approach. Right. So can you move on? What is your procedure of choice now in this case?
So in this case, laminectomy was done.
Now, what would you do? Have you done this?
No.
What would you do? What is the advantage of a laminectomy? What is the disadvantage of a laminectomy?
So in laminectomy, the pathology is not approached directly, but the cord is allowed to fall back and we achieve indirect decompression.
So laminectomy was done from what level to what level?
C3 to C6.
Yeah, so that's the advantage or a disadvantage of a posterior procedure. That if you have to go posteriorly, you have to go all the way, from C3 down to C6, and there are a lot of issues with this. So the procedure of choice, if you are sure you can go in and do a good job, is always anterior, right?
Okay.
Fine. So
Only after you are done.
Yeah. So go on, Samir. Go on.
So if you all are done, I would say my thoughts on this case is that this is definitely an OPLL, and he's got a very narrow canal as well, and he's got an almost straight spine with a little focal kyphosis. I think what I would do for this patient is posterior surgery, and I would add a fixation for this patient to recreate the lordosis. And I think that will be enough for the patient. The patient will not require anterior surgery after that. So a posterior surgery will address the stenosis. Because we are giving it a bit of lordosis, there'll be a cord fallback, and that will be enough, and also prevent further growth of the OPLL mass as well as any post laminectomy kyphosis. So my procedure of choice would be that.
Right. So Amaya, that's an interesting point.
Yes.
When you said a laminectomy was done, what do you see what is the disadvantage of laminectomy in this? The advantage, obviously, you told that you probably decompress the cord. Do you think that the cord will be adequately decompressed with only a laminectomy in this case?
No, but we can expect it, sir, indirect decompression. And
For
disadvantage is
your
that
indirect decompression to happen, your cord has to fall back. That means that you need a lordotic alignment of the cervical spine, right? You need a
long-term
lordotic alignment.
kyphosis can happen.
Right. So one is you might not be sure of a decompression unless you add instrumentation, as Sangeet said, because you want to pull the column back in lordosis. And the second thing is that in an already kyphotic cervical spine, by doing a laminectomy, you are removing the posterior tension band structures, risking further progression of kyphosis. Right. And once you have done a laminectomy, you have lost the posterior sort of fixation points also. So if this patient were to progress in post laminectomy kyphosis, you would probably have a little bit of tough time managing it. Having said that, both the options are equally right.
Go ahead, Dr. Abhay. What was done for this case?
Sir, posterior C3 to C6 laminectomy was done.
Okay.
I do not have a post.
Do you have a post-operative MRI in this case?
No, sir.
So can you tell us something about the neurological recovery this patient had and the issues?
Yes, sir, this was done just a month back, so it will be very early to judge.
Right. So what are the anticipated issues that you expect in this patient on a long-term basis?
There might be OPLL may grow to adjacent levels.
Why? Why will the OPLL grow?
Because there will be more degeneration, and if there is a tendency of OPLL to happen, so it can happen at adjacent levels. Also, there will be micro instability.
Right. So OPLL probably might increase because of micro instability over there. Okay, you're not exactly eradicated. Fusion probably might arrest, but again, that's a debatable topic. Okay, anything else? What about the function of the patient, the neck pain? In a kyphotic spine, the patient already must be having a little bit of neck pain. If you've done a laminectomy, probably you are increasing you're putting the patient at a risk of developing more neck pain. And third is post-laminectomy kyphosis, right?
Yes.
So if I were to do this, I'll probably add instrumentation like Dr. Sami said, or look at the possibility of going anteriorly because it's a focal kyphosis. If I was sure I can go all along the OPLL mass, it gives me a good chance to do a good decompression and also restore the lordosis.
Yes,
right?
sir.
Yeah.
Thank you, Dr. Ramaya. I would like to once again check if Dr. Sandeep Sonone's pre-recorded video is working or not. I'd like to just...
So just one more thing, when it comes to doing 360, one more indication is if you have a more than 60% canal compression from anterior, and if you are having on CT or MRI, you see more than 60% of the canal is getting compressed anteriorly, then of course you should consider a 360, considering that you have to go anterior because no way you can manage that posteriorly. So that another one more indication for a 360 procedure. Just wanted to.
Agreed.
All right.
But I just want to say that if there's a patient who you're doing a posterior and anterior surgery, I would not do it in one sitting. I would do a posterior surgery and then see the patient later on, see the recovery and look at the MRI and only then go for the anterior.
Yeah, that could be the case. That is individually depending on whatever patients you have and everything. But of course, you can wait. There's no harm in waiting. But normally, most of us will do that. Do a stage surgery sort of.
Right.
Okay. I'd like to check if the video is playing or not.
Degenerative cervical myelopathy could be multifactorial in origin
Is the video playing?
Yeah, it is. It
All
is.
right.
with varied etiology, which may cause cord compression. It can also result in progressive kyphosis and cervical instability, and that can give rise to this clinical complex of neurological deficit with severe neck pain. Now, there could be static factors like a congenital canal stenosis to begin with, the disc, the facets, the hypertrophied ligamentum flavum, the calcification, and occasionally the ossification can contribute to it. The dynamic factors like microscopic repetitive trauma, which happens during flexion extension, and the presence of cervical instability can combine with the static factors and result in ischemia of the cord, giving rise to clinical symptomatology. Now, when we see a patient of cervical myelopathy, the but obvious questions which come to our mind are, what is the management? Is it non-surgical or surgical? If it is surgical, is it anterior, posterior, or does this patient require both the approaches? If it is anterior, what do we do? Do we do multi-level discectomies, or we just do a corpectomy and get the compression out from top to bottom? If it is posterior, which procedure is the best? Is it laminoplasty? Is it laminectomy? Or if so, will adding an instrumentation help? If it is a combined approach, which one do we do first? And finally, what is the prognosis of this particular patient? Now, regarding the management, there is an overall consensus that non-operative treatment in cervical myelopathy has a very poor prognosis. There are two main patterns of progression. One is where the patient deteriorates over a period of time. And the second is that the patient is clinically stable and suddenly there could be an episode like a micro trauma, which can sort of expedite the whole process. Now, there are multiple studies, and this one done by Clark and Robinson, where they treated 120 patients non-operatively. And in all those 120 patients, none of them had complete recovery of symptoms. In fact, most of these patients deteriorated. In another study by Roberts, he found that at the end of 6.5 years follow-up, 1/3 of the patients had improvement, 1/3 did not show any improvement, and 1/3 of the patients actually experienced deterioration with progressive worsening. So, conservative treatment is usually advised in mild cervical myelopathy, where the transverse diameter of the cord is more than 70. It has got a high risk of progressive neurological deterioration and poor outcome. It is not recommended in moderate to severe stenosis. The surgical treatment should always be considered for patients who are more than 55 years of age. The rationale being, surgery may halt the progression of myelopathy. It may or may not improve the neurological status, but it definitely improves the functional quality and functional outcome in the quality of life. And there are some reports which suggest that there could be improvement in the pulmonary function as well. There are clinical guidelines where mild cervical myelopathy can be offered a trial of rehabilitation. Surgery is definitely indicated with moderate to severe cervical myelopathy. Prophylactic surgery, depending on only the radiological picture, should be avoided. And if there is a radiculopathy, that is pure radiculopathy without presence of any myelopathy, in presence of radiological stenosis, then these patients have a definite chance of neurological worsening. Now, the decision regarding the approach will depend on a lot of factors like etiology. Multi-level disc affections can be managed by either anterior approach or posterior approach, but posterior is preferred in OPLL cases. Location of compression, if there's an anterior compression, obviously we need to go an anteriorly. The alignment of the cervical spine, we all know that posterior procedures work best when the spine is in either neutral or lordotic alignment. Anterior approaches are more reserved for a single or double level pathologies. 3 or more than 3 posterior approach works well. Clinical presentation, if the patient has got pure myelopathy, then posterior approaches work well. MRI changes, definitely they will have a say. And obviously the morbidity factors. The posterior approaches are considered to be much faster with fewer complications as compared to the anterior approaches. However, if all the factors are evened out, then meta-analysis studies show that the anterior approaches have a better clinical post-operative scores and neurological recovery, but they are also associated with increased operative time and higher rates of complication. However, long-term studies do not show any difference between these two groups. Now, if we perform the anterior approach, there's always a dilemma between multi-level discectomies versus corpectomies. And again, meta-analysis studies show that there's no significant advantage of one over the other. If there is retrovertebral compression, then corpectomies do the job better as compared to multi-level discectomies. But we need to individualize each and every case. Or maybe in conditions like this, we need to strike a balance by doing a hybrid construct so that we achieve a good amount of balance between maintaining the lordosis and sort of trying to do a complete decompression of the cord. In the posterior approaches, there are basically 3 procedures: the laminoplasty, the laminectomy, and laminectomy with fusion. Laminoplasty is basically indicated for predominantly posterior compression. It should be attempted in neutral or lordotic spine. It is basically a motion preserving procedure, and it avoids the post-laminectomy kyphosis because we retain the posterior ligament. However, a significant amount of kyphosis, and the value which has been mentioned is more than 13 degrees, is a contraindication because it doesn't allow the cord to fall back. Neck pain is another contraindication because we will be stripping the muscles of the lamina on one side. The clinical outcomes are, the clinical scores are quite good in short and mid and average in long-term follow-up. However, there's a decrease in range of motion. There is a little bit of loss of cervical lordosis, not as much as compared to laminectomy group, and axial neck pain is pretty common, although there's a good neurological outcome. Laminectomy is again indicated in multi-level posterior compression. The prerequisite is again you need to have a neutral or lordotic cervical spine. It is also indicated in cases of an OPLL where anterior surgery is supposedly very risky. The contraindication is kyphotic alignment and preoperative instability where you might have to add in the fusion. Now here you can see that kyphosis is a contraindication because it doesn't allow the cord to fall back. And there is a significant amount of post-laminectomy kyphosis in presence of severe instability and in young patients. The clinical outcome, however, the recovery rate is comparable. There's more than 50% improvement in the clinical scores. And because we are stripping the muscles of all the of the attachments on the lamina, there is a significant axial neck pain, and the incidence of post-operative C5 palsy is quite high. An addition of fusion in the relatively young patients overcomes this issue of post-laminectomy kyphosis. It helps in pre-existing instability and also in OPLL, where stability might have a role in slowing the disease process. The contraindications are osteoporosis, and obviously it's a morbid procedure, especially because of the length of the surgery and the blood loss. The radiological outcomes are pretty good. There's a good correction of alignment of the cervical spine. And because the cord fallback is highest in this group, there's the highest rate of post-operative C5 palsy. Also, meta-analysis studies have shown good fusion rates and low rate of revision and disease-related complications, especially in the multi-level degenerative cervical spine. Hence, it is currently the most favored treatment by most of the surgeons. A combined procedure is mostly indicated in fixed kyphosis, in severe OPLL with focal cord changes. It's usually the posterior first because the rationale is you allow the cord to fall back and then you can do a targeted anterior decompression. It's a morbid procedure, obviously, because of the age of the patients where this procedure is performed. And again, the clinical radiological outcomes are as good as a posterior procedure. So that's the summary in cervical myelopathy. Thank you very much for your attention.
Thank you, Sandeep sir, for a wonderful summary. We would like to move on now. Can I have Dr. Subhanshu share his screen and start with his journal club presentation?
Yes, sir. Good evening, everyone. I'm Dr. Subhanshu Valadare. I'm SC Fellow with under Dr. Abhay Nene at Leelavati Hospital. Today, I'm going to review two articles. As we know, cervical spondylotic myelopathy is a slowly progressive condition with waxing and waning periods in which not all the patients are symptomatic. However, in a symptomatic patients, MRI are the investigation of choice. Though the CSM is cervical spondylotic myelopathy is a slowly progressive condition. Some patients deteriorate faster, and thus a term rapid progressive cervical spondylotic myelopathy was given by Wang Zhong et al. In this study, where we studied the risk factor for rapid progressive neurological deterioration in patients with cervical spondylotic myelopathy. It was published recently in the Journal of Orthopedic Surgery and Research. The aim of the study is to investigate characteristic and potential risk factor for rapid progressive cervical spondylotic myelopathy. After institutional review board committee approval, informed consent taken, it is a retrospective type of study. Here, rapid progressive was defined as the symptoms less than 1 month, causing difficulty in maintaining a standing posture or walking without support, while a chronic CSM is defined as more than 1 month of symptoms. Inclusion criteria include severe patients with a failed conservative treatment, suffered with a rapid progressive CSM, chronic CSM, and underwent surgery 3-4 days after the admission. Exclusion criteria include a metastatic fracture, primary tumor, history of any cervical spine injury, high energy trauma fracture, history of cervical trauma or infection. The surgical technique used in this study is ACDF, ACCF, posterior laminoplasty, laminectomy, and fusion, and in some cases, hybrid anterior plus posterior. Hard cervical Philadelphia collar was given for 6 weeks post-surgery. The outcome assessment was done usually of the neurological status with modified JOA. Congenital stenosis in radiological assessment was done by torque-Paulo ratio if it is less than 0.75, while degenerative spinal stenosis torque-Paulo ratio between 0.75 to 1. Statistic assessment is done with the univariate analysis to compare pre and post-operative outcomes comparison, while multivariate analysis for factor associated with rapid progressive CSM. These are the results. Out of the 159 patients, 34 patients were identified as rapid progressive CSM, while mean follow-up for the rapid progressive CSM was 68 months, and chronic CSM was 63 months. There was no significant differences found between the two groups in sex, mean age, smoking, diabetes mellitus, hypertension, blood loss, mean modified JOA, congenital or degenerative spinal stenosis, or OPLL. No significant differences in between the different surgical approaches between the two groups. While the univariate analysis shows a rapid progressive CSM patient tend to have MRI T2 hyperintensity, longer hospital stay, and shorter waiting time for the surgery, while the multivariate analysis show congenital stenosis, MRI T2 hyperintensity as the independent risk factor for developing rapid progressive CSM. CSM carries a high risk for disability even after the surgery. In this study, 88% of rapid progressive CSM shows T2 hyperintensity signal, which is suggestive of ongoing ischemia, demyelination, oligodendrocyte dysfunction, while the congenital spinal stenosis reduces spinal canal diameter and increases the chance of spinal cord injury. CSM patient with a congenital stenosis should be followed up regularly. Previous literature suggests diabetes mellitus as a risk factor, though the author in this study did not find any correlation between CSM, diabetes mellitus, smoking, and hypertension. Though an overall MGA score improved in both the group post-operatively, rapid progressive CSM showed a good neurological recovery suggestive of its reversibility. Limitation of this study is a retrospective study. Definition of rapid progressive CSM is only clinically and not included any biomechanical factor or any pathological issue. While only T2 sequence are studied, no other sequence were studied in the MRI. The take-home message from the study we got is that the MRI in MRI T2 hyperintensity and congenital cervical stenosis are two risk factors for identification of rapid progressive CSM. Rapid progressive CSM with MRI T2 hyperintensity require early intervention, and early surgical decompression is recommended and could achieve a good neurological recovery after surgery, indicating it is a reversible condition. This is the second paper in which I am going to talk regarding the review of degenerative cervical myelopathy.
No, Shubhanshu,
Yes.
just one sec. Can you just, regarding this first paper, some questions. Have they differentiated the number between the disc cases and the OPLL cases? Have they given what is it? Because in this case, what I can understand is that they say that surgical results has got good results. You know?
Yes, sir.
So in this case, have they actually categorized the patients who were OPLL cases and disc cases?
Sir, they have written here that there is OPLL. They have not mentioned anything in the paper, but in the table here, they have mentioned that in rapid progressive, there are 5.9% of OPLL cases, and in chronic CSM, there are 7.2, and the p-value is not significant. So they have mentioned it that OPLL in both the cases doesn't show any significant difference.
No, but in this case, the incidence, the actual incidence of OPLL cases is very less. You know,
Yes,
I mean, 6%. So that is something that we need to take it with a pinch of salt. You know, so the understanding is that OPLL is a different. The results in OPLL will be totally different than results in a disc case, right?
Yes.
Second thing is that is there a demarcation between the pre-operative JOA scores where the patient has suddenly started deteriorating? You got my question. Like they had JOS scores which when the patient deteriorated to a particular score, and after that there was a sudden deterioration. So is there a cutoff point in this particular paper?
No, sir, nothing mentioned regarding that.
Anything about the radiological parameters, the amount of kyphosis in these patients?
No, sir.
Because see, I mean, in a patient who's a severely kyphotic cervical spine, you know, if you are doing just a posterior surgery, then probably, you know, you can't say that this patient is going to totally recover, like what Dr. Ayush said, the K line, you know, so that is a very important factor, especially in the OPLL cases and also in kyphotic cervical spines. And finally, what do they actually mean by good recovery? Good recovery for what? Radiculopathy, myelopathy, how much is the grade improvement in terms of JOA scores, in terms of functional outcomes like the numeric scores? So what do they mean by good recovery?
So they have mentioned that there was improvement in overall JO score. So we can see in the table also. From 14 in a rapid progressive to 16, it has improved. While in chronic, 13 to 16, it has improved. Similarly, but there was no, between the two group, there was no significant difference. So they are suggesting it doesn't affect the which way you go.
Because if you see in the same chart, if you see critically the MR intensity changes. The rapid progressive group says 88%, where the chronic progressive group says 24%. So there's a significant difference, right? And our understanding is that MRI intensity change on a T2 weighted image has got a poor prognosis. So probably this is something which you need to take it with a pinch of salt. You know, like MRI showing that there's a 3 times more incidence as in another group as compared to one group. And ultimately the functional recovery in both the groups is same, which is something which we are not used to, hearing. So that could be one of the drawback of this, study.
Even the type of compression they should mention, because we know patient who have the hill type compression, and even with a certain, with very minimal jerk, they will have a certain deterioration, and that is the most common scenario of a certain deterioration. Even though they won't realize, sometimes we had patients who got up in the morning and there was a certain. So that small things, if you take in consider, this paper is very, very biased and very superficial.
Yeah, I agree.
They have not gone in the detail of the scenario. They just given an overview. So very difficult to agree to this rapidly without knowing the fine print of what was happening.
Right. Yeah, we move on. Next page.
Go ahead, Dr. Subhanshu.
So this is my second paper. Where it is a review article which is of degenerative cervical myelopathy, which gives us insight regarding past, present, and the future direction in case of degenerative cervical myelopathy. As we know, degenerative cervical myelopathy is an age-related condition that result in a neurological injury through a dynamic or static mechanism. In the past, OPLL is considered as a part of CSM, which leads to the hindrance with literature synthesis, as consequently hindered many line of investigation. Example, evaluation of prevalence rate for specific phenotypes or natural history and surgical decision making. However, a new term coined by Nuri et al. In 2015 called degenerative cervical myelopathy encompasses both CSM and OPLL, and also more clearly recognizes the degenerative nature of the disease. In the past, surgery was recommended to arrest further neurological decline. However, recent studies have suggested that many patients with DCM who has been advised surgery not only stop neurological decline but also improve. And this has changed the decision-making process in case of degenerative cervical myelopathy. And they have said that irrespective of the age, there some change in the recovery they have noticed in and around MJ score improved from grade 2 to grade 3. Asymptomatic DCM should not be recommended surgery, while mild myelopathy can be offered surgery or supervised surgical rehabilitation. In the past, congenital cervical canal is cause for one of the cause for developing DCM. However, recent data suggests size of canal and cord both matter for the development of DCM. So a new term called spinal cord occupancy ratio was identified, which suggests that 70% occupancy of cord in mid sagittal, more than 70%, and more than 80% in axial cuts are more prone for development of DCM. In present scenario, there is a lot of literature regarding anterior versus posterior surgery. So the complication associated with the anterior surgery is mostly post-operative hematoma, hoarseness, and dysphagia, while posterior surgery causes greater length of stay in hospital, cost, general medical and surgical outcomes. The indication for anterior surgery was given as anterior compression and cervical kyphosis. While the posterior high degree of posterior cord compression, congenital stenosis, and multiple compression, and as well OPLL. And most of these are based on the cervical alignment, in which if C2 C7 angle, the kyphosis is more than 30°, then a need for anterior with regard to with addition to posterior is suggested. While if T1 slope is high, risk of kyphosis development in patient with laminoplasty is more. And term for K line is given if it is modified K line. If the anterior pathology is less than 4 millimeter of the K line, then it is more prone for uh, post laminectomy kyphosis and needs an anterior surgery. In the future, there should be multiple dimension approach to the surgical outcome measurement. Prediction model should be built upon MRI and clinical data to know the predictive capacity of this model, which will tell us regarding the natural history and whether the certain DCM will progress or not. Model developed on advanced MRI, including gray to white matter ratio, DTI, fraction, anastrophy, and electrophysiology, may improve ability to predict surgical outcomes and need further studies. There is one term given in the study called as corticospinal reserve capacity, in which transcranial magnetic stimulation is done, which is a non-invasive method to stimulate brain, which suggests a decrease in corticomotor activity and a compensatory increase in supplementary motor activity. This gives an idea why in some patients with a certain degenerative condition in the spine, they show no symptoms or a mild symptom, while in some patient with a mild cervical disease, they show more neurological symptoms. Also, there was in the future there are development for biomarkers, including advanced MRI, like I said, anastography and electrophysiological studies. Blood markers such as miRNA-21 for which is suggestive of neuroinflammation, MIR34A neuronal apoptosis, and MIR10A for OPLL. In conclusion, DCM is ever developing clinical condition which leads to extensive residual disability. Research suggesting time of surgery regarding methods to achieve neurological recovery should be done. And prediction model, including recent advances in MRI and electrophysiology, should be included and researched. Thank you.
So Subhanshu, in this particular paper, they have actually spoken of neurological improvement. You know,
Yes, sir.
Is like our conventional belief was that patients will either remain static or they may or may not improve. But now this paper is suggesting that the pendulum is swinging towards the opposite side and they're actually improving.
Yes, sir.
In this particular paper, although it's more like they're just giving the information more than a paper. Have they spoken somewhere of post-operative deterioration in the neurology? Not because of anything else, but because of a good surgical decompression.
No, sir. Nothing is mentioned. They have said that after anterior surgery, there might be some complication, more neurological compared to posterior, but nothing much more than that.
So, are you aware of any condition where the patient can actually deteriorate post-operatively after a good decompression, and what could be the reason for that? Anybody else?
So there is the reperfusion injury, which is a known entity and has been published in literature, especially seen after a very tight canal with severe stenosis and OPLL. Sudden decompression of the spinal cord can result into transient paralysis and related to the increase in the vascular supply to the spinal cord.
Yeah, so that's a very interesting concept, because just half an hour back, Dr. Sameer Darvi said that he would probably wait. So we had one patient in which we did both the procedures together, a posterior followed by an anterior, and the patient deteriorated rapidly. And then we went back and found out, I went through the whole, mental exercise of going through the steps of what actually could have gone wrong. We did a CT scan, everything was fine, and ultimately it turned out to be a reperfusion injury. So the concept is that the cord is compromised, the vascularity is compromised, the vessels are collapsed, and suddenly when you open up, the sudden gush of blood into the intraneural tissue, and that can actually cause more cord edema, and that can cause a post-operative deterioration, right? So the second point, yeah, Ayush, go on.
Yeah. So a few things just I wanted to add that definitely the recent evidence suggests that there is improvement happening in myelopathy. Even in our latest publication, we reported 66% improvement in neurology, which is really good, and that is where the literature goes. The other two things which is happening in recent advances is a lot of focus in neuromodulating drugs, and they are from the Toronto group from Michael Felling's Rizolock or something, and even Rajshekharan has done some amount of work. So there is refocus happening on these drugs, which does. So some part of it is decompression, but the other part is the neuromodulation, which has not been dealt with. So there is a refocus on the neuromodulation, and there are few drugs. One we investigated was the cerebrolysine, and the other is from the Michael Failing groups. These things are coming up, and we are hopeful more and more drugs will come. The other factor which has come into picture is the intraoperative blood pressure, which again has with the neuromonitoring and everything. We didn't talk about that, but there is definitely some evidence that it is very, very vital to maintain it, especially with cervical myelopathy, and you should have at least the mean BP around 85 to 90. In our latest research, we have gone ahead and said that it should be even at a higher level, and that is likely to have some neuroprotective effect on that. We have just been accepted with that with NAS, and we are hopeful we'll publish it very soon. And these are the two areas where we feel there is a refocus, and there is a lot of improvement can be done in the results and the recovery when it comes to cervical myelopathy.
Right. Another factor which I wanted to touch upon is that you mentioned a very good thinking concept, that the spinal cord occupying ratio, right? That's what you said, the SCOR. So what do you make out of this? What do they actually want to tell us through this particular new term which they are sort of new measurement which they are putting inside?
Sir, they want to define
Can you just go back to the slide? Can you just put up that slide? The SCR one? Yeah, this one, right. So what does it signify?
So there was, before we used to calculate a torque-Pavlov ratio, which is one unidimensional thing, while spinal cord occupancy ratio will tell us about more definite involvement of the stenosis or anything in the cord injury, in case of a cord injury.
Yeah. So the initial concept was that we thought that the canal was the offending structure, right? The canal was narrow. Now they are believing that this could be one of the factors. The other dimension is the cord itself is big, right?
Yes.
So it's not the canal which is the offending element all the time. It is narrow, fine. But had the cord been proportional to the canal size, probably these patients may never develop myelopathy. It is the cord which is big in size. That's why the cord is getting pressed itself from all the circumferential areas, and that's one concept that we need to understand. The third concept is regarding the T1 slope. So if you can just explain us the T1 slope, what actually do you make out of this particular thing? Yeah, the T1 slope, right? Yeah.
So T1 slope is calculated by drawing the line along the line along the vertebral body superior surface and a line and a horizontal line. Normally, it is suggestive of a lordosis. If it is if it is less, then it is suggestive of kyphosis.
No. See, the T1 slope doesn't depend on the cervical spine, right? The T1 slope is a parameter of the thoracic spine. It's not of a lumbar spine. You got me? Right?
Yes.
So in this case, when there's T1 slope, suppose the T1 slope is less and the T1 slope is more, how does it influence your management of the cervical spine? Slope is less, fine, you can go ahead and do whatever you want to do proximally. Slope is more, still you can go and do it whatever you want to do proximally. So how does it affect the cervical spine management?
Yes, sir. They have mentioned that high T1 slope causes increased chances of kyphosis, especially in laminoplasty and
Right. So the whole concept is that it's like a pelvic incidence in the lumbar spine, right? It is the lumbar lordosis is trying to match the pelvic incidence. In
Yes,
this
sir.
case, the thorax, the cervical lordosis is trying to match the compensate for the T1 slope. Okay, so if you're not able to give that much amount of the lordosis, then there's every possibility that due to additional effect, the patient is going to topple down. Right? So lesser the T1 slope, less the chance of the patient landing up in post-operative cervical kyphosis. If the T1 slope is more, the patient may not be able to manage it. Okay, manage the whole lordosis in the compensated lordosis in the cervical spine. So his occiput is falling anteriorly, and then that keeps on adding because the C2 SVA goes far away from the C7 SVA, and that is how the distance increases and the momentum adds to it and the kyphosis increases.
Okay, sir.
So that's why they say that if the T1 slope is more, like Sami said, in addition to a posterior procedure, you need to add instrumentation to give lordosis to the cervical spine, which is matching exactly the T1 slope. Right?
Yes.
So that's the whole concept. Right. I think we can move on if the other faculty doesn't have anything else to add.
Yeah, I think we can discuss the cases of Dr. Subhanshu.
So this is a 50-year-old male with a sedentary lifestyle, which is complaining of difficulty in walking since 6 months, change in handwriting since 3 months, and no gallbladder involvement. On examination, power is normal, reflexes are exaggerated, incoordination is present, and tandem walking was difficult. This is the X-ray of the patient.
Okay. Would you like to describe the X-ray also, Dr. Subhanshu?
Yes, sir. The X-ray is showing a decrease in the disc space at C3, C4, C4, C5, C5, C6 level, and also the lordosis of the cervical spine is maintained in lateral view. And
why is there change in handwriting, Subhanshu?
So the fine motor function start affecting because of the incoordination he's saying.
But why? Why is the what's giving this incoordination? There is a compression.
Sir, at cervical level.
अरे cervical ही होगा ना, lumbar थोड़ी होएगा. So where exactly is the compression? Is it on the cord or the nerve roots? Or is it a high cervical myelopathy?
In the cord only.
So why should cord cause change in handwriting unless it's a high cervical myelopathy? It's basically root affection, right?
Okay, yes, sir. Yes.
It's basically the upper limbs are getting affected. As I said, unless you are suspecting a myelopathy quite, at a upper level like C1, C2, right?
Yes,
in
sir.
that case, these patients will have signs of not only they won't have change in handwriting because change in handwriting is fine motor function. So that is because of root involvement. So now in this case, you know that this patient is basically come to you with a symptomatology more of radiculopathy rather than myelopathy. Because if you see the power is 5/5, the
Yes, sir.
patient has got early myelopathy. The reflexes are exaggerated, which is grade 1 neuric.
Yes, sir.
Right? Unless maybe grade 1 or 2 because he's got difficulty in walking also. Right? So radicular symptoms more than myelopathy symptoms. Right?
Yes, sir.
So this is what we can interpret.
And possibility of other disease like Parkinsonism should be ruled out.
All right. Okay. Yeah.
Yes. Dr. Subhash.
So this is the MRI of the patient, which is suggestive of OPLL extending from C3 to 6 level, C6 level, with the myelomalacic changes at between 4-5 level.
Why OPLL? Because you see the CT scan.
There is a continuous hypointense signal extending from C3 intervertebral disc till C6. There is no posterior vertebral body hyperintense signal which is normally seen.
What type of OPLL is this?
This is a continuous type of OPLL.
Okay.
These are the axial images.
So can you explain the axial images? Now, since you committed that this is an OPLL and we agree to it, can you just tell us more information about the OPLL from a management point of view?
Sir, OPLL generally is a progressive condition and it is caused by microinstability happening at a cervical level. In the management part,
what's the basic pathogenesis behind the OPLL? The etiopathogenesis? Is it calcification in the normal ligaments or abnormal calcification? What is it exactly?
So it is an abnormal calcification in the normal OPLL. PLL, posterior longitudinal ligament.
Yeah. So if you see the OPLL mass, they come in all sorts of shapes on the axial scans, right?
Yes, sir.
So normally the PLL is not attached like this. It's not all around, right? It's thick in the middle. And as you go on the periphery, you must have realized during doing an anterior cervical decompression, it's quite thick in the middle. But as you go laterally, it's quite thins out. But if you see the OPLL mass, it's not that. It's not only calcification in the PLL. So initially it starts in the PLL, but it's like a fungus. It keeps on growing all around. And that's why only arresting or only decreasing the mobility of the spine doesn't stop the OPLL from progressing. Whereas in a cervical myelopathy, if you do a posterior decompression and stabilize the spine, the cervical myelopathy pathology might not progress. But in this case, the OPLL will keep on progressing. So that's the basic difference. Okay?
Yes, sir.
Right.
What would be the plans for this surgery? Anterior, posterior, or hybrid? Anterior plus posterior.
CTVT कुछ किया नहीं क्या?
नहीं सर, CT नहीं है इसका.
क्या रे KM का पेशेंट है क्या?
नहीं सर का अभय सर का पेशेंट. 2007 का पेशेंट.
Okay.
I think can we have Dr. Abhay tell us the plan for this?
Sir is not there, I think.
Abhay is not there. I will. Can we have Raj, Dr. Raj Sakrekar?
Yes, sir. Hi. So, considering the continuous OPLL, as we discussed throughout the session, I will first plan to go posterior, do posterior laminectomy followed by fusion to achieve the lordosis, as well as I will think of considering foraminotomies to prevent the postoperative C5 palsy. Hope to see the recovery of the patient. If patient recovers, then nothing doing. If patient recovery is still guarded, then can think of adding anterior also, sir.
So Raj, why do you want to add instrument in this case?
Sir, I can't actually figure out the amount of kyphosis, K line and angles.
So if you look at the cervical spine, the overall alignment is in lordosis, isn't it?
Yes, sir.
And even if it is in kyphosis, up to what amount of kyphosis can you actually get away with a posterior only, without adding instrumentation?
Yes, sir. Even throughout the results of the fusion, fusion will help
to reduce the post-laminectomy kyphosis in the future, and the fusion will help to stabilize the spine. So preferably, I will like to add the fusion, considering patient might have post-laminectomy kyphosis.
So see the incidence of post-laminectomy kyphosis, is almost 10 to 30%. It's not 100%. So all these patients won't land up in post-laminectomy kyphosis. There are certain indicators, right?
Yes, sir.
Now in this case, if you see the alignment of the cervical spine, it is in lordosis. The patient has got cord intensity changes, which is at the apex of
OPLL.
compression.
Yes, sir.
Okay, so you expect, if you do a good posterior decompression only, you expect a good cord shift back. Okay, cord will fall back quite well.
Yes, sir.
Now regarding instrumentation, you need to take into account a few things. One is the amount of neck pain this patient has.
Yes, sir.
If the patient has got significant neck pain, then instrumentation is needed.
Mhm.
But if the patient doesn't have too much of neck pain, then you can get away with a posterior decompression, which is either a laminectomy or a laminoplasty.
Got it, sir.
Right? So that is how you decide. So in a lordotic spine, if the patient doesn't have neck pain, don't be in a hurry or think of instrumenting the spine. Because
Okay.
the disadvantage of instrumenting the spine is that you're losing out on a lot of motion in the spine, right? Which you can retain with other things.
Okay, sir.
There are other factors, like if the patient has got significant lordosis, the T1 slope, a posterior procedure would work equally well, right?
Okay, sir.
Yeah, go on. So
Go ahead.
So this is the post-op of the patient. Since the patient age is 50 years, we planned on doing instrumentation also for the patient with cervical laminectomy at that time.
right. So what are you said something about a C5 palsy, right? When you
Yes, sir.
spoke of things. So I think who said? Raj said of C5 palsy.
Yes, sir. C5 palsy, I mentioned, sir.
So what's this concept of C5 palsy? Why does the C5 palsy happen
Yes,
in
sir.
posterior procedures?
Yes, sir. As we decompress the cord indirectly, so the cord will fall back. So the nerve roots which are emerging from the cord, like C5, they will get compressed in the foramen, leading to the C5 palsy, deltoid palsy.
So why only C5? Why not C3? Why not C4? Why not C6?
As per the alignment, the C5 is at the more a lordotic posture. So
It is at the
C5
apex
is
of
at,
lordosis.
yeah,
At the apex of lordosis.
it's
Right.
at the apex of the lordosis. So C5 is eventually gets more affected in the cord fall back.
So what sort of palsy is this? Is it a compressive palsy? Do you feel that the C5 nerve root gets compressed when you decompress the cord?
No, sir. When the cord falls back, at that moment of time, the nerve root gets compressed because of the fallback of the cord.
So the C5 palsy is basically a traction palsy.
Traction palsy, yes.
Right? It's a traction palsy. It's not a compressive palsy.
Yes, sir.
So that's why, when you speak of doing a foraminectomy, we have had patients where the patient has got a C5 palsy without doing a foraminectomy. We did a foraminectomy in going into the in a tight foramen. The patient still had a C5 palsy. So and this is a universal. This is the universal literature. Nobody knows whether a foraminectomy really helps or not as regards the C5 palsy, because it is essentially a traction palsy.
Okay.
And one of these things, like a reperfusion injury, C5 palsies will never happen immediately. It's not like you go in the ward on the day of surgery and the patient has got weakness. Maybe on second day or third day, the patient will start complaining of weakness. And this is again because the cord fallback doesn't happen acutely. It happens gradually. So
Yes.
the traction on C5 nerve happens gradually, and that is how they develop these palsies. And all these conditions like a traction palsy or a reperfusion injury, they are basically reversible injuries. So that's why we see that a C5 palsy, if you detect it, it has got a very good prognosis. It will recover. It will take 9 months, a year. It will definitely recover unless you have damaged the root while doing a foraminectomy. So the role of foraminectomy is very, very controversial. Although I always do it now.
Okay, sir, got it.
Any opinions from Akhil or Ayush? Anything to add? Yeah, Ayush.
Yeah, just one thing. If we can go back to the scans. Just go back to the first scan. Yeah, go back. Yeah. So if we see that the compression is in, yeah. So compression is even the posterior the element is even compressed up to C2. So all these cases I normally prefer to undercut that C2, and that because if we and that is what the post op MRI will show. So still, like, it's a very good result, but it's always better to do one thing. If you see something like that, you can easily undercut the C2, or at least pass a pen field and see after the cord fallback if there's still a compression, and then make sure that both at the top and the end, for example, whatever is your the distal and the proximal limit, just make sure that you after cord fallback, because the cord really falls back sometime and it can impinge on the proximal or distal junction. So you can simply undercut it and preserve everything. So just one something.
So one question for Subhanshu, like Dr. Ayush said, he wants to do an undercutting. So a couple of questions is that you're doing a laminectomy all over, right? You're going from C3 down to C7. Why not do a C2 laminectomy?
So C2 in C2 the main muscles of the stabilizer of the necks are attached.
Right. So the
C2
most important stabilizers of the neck are attached to the C2 tip. So I have seen people do a laminoplasty or laminectomy by exposing the C2 spinous process also. So that is something that you should avoid. The whole idea of preserving the C2 lamina and the spinous process is the muscle attachments. So make sure you don't expose of the muscle attachments where you're doing a C3 to C7 laminectomy. Otherwise, the whole purpose is lost.
Yes.
Right. And if you look at the post-op MRI, this is what Ayush was exactly speaking, that although you got a very good cord fallback, the patient might have recovered, but look at the C2. So this is what he was telling about, that undercutting, probably it would give a good radiological picture, although this patient functionally might have recovered. Right? Yeah, can move on. Yeah.
Just go ahead, Dr. Subhanshu, to the next case.
There is a 56-year-old male with complaining of loss of balance while walking since last 3 months and difficulty with fine motor activities. There is no history of gallbladder involvement. On examination, gait was myelopathic, core was intact, and the reflexes were exaggerated. This is the X-ray which is showing reduction in the disc space between C3, C4 disc space with the marker pointing at disc osteophyte complex, and also reduction in 4-5 disc space. Overall, the alignment of cervical spine is lordotic.
Right, yeah, go
on. This is the MRI picture, which is suggestive of C2, C3 disc space reduction with a prolapsed intervertebral disc causing compression of spinal cord and myelomalacic changes in the spinal cord. These are the axial cuts, which in which we are able to see between C through C4 there is a huge disc pressing on the spinal cord. While we further did.
So Subhanshu, just one question. In this case, if you go, can you just go to the slide with the symptoms, the complaints? So we believe that this patient is basically a disc prolapse patient, right?
Yes, sir.
Looking at the so in this case, are you sure that this patient did not have any acute injury? Because if you look at the spine and even the disc which is affected, it's not very bad. It's not like it is kyphosis. It's not too much of disc the disc collapse. It's not very bad like we see normally. So now you go to the MRI and look at the MRI picture. So would you anticipate something more in this case? Look at the posterior elements. There are significant hyperintensity changes, especially in the second column, second row of the MRI. So in this case, you need to be sure that this patient did not have a whiplash. So he had a
Okay.
stenotic canal initially, but
Yes.
because of some injury which he may or may not recover, this patient has landed up in these symptoms. And I definitely can make out some changes in the posterior ligaments over there, which is indicative or probably indicative for an injury. I might be guessing it, but that is something that you need to be sure of, especially when you know that it's a disc case. Disc patients more often than not with intact disc space will present more with the radicular symptoms rather than with myelopathy symptoms.
Yes, sir.
Right? Yeah.
So the cord is showing some myelomalacic changes, so that won't suggest a myelopathy.
Yeah, there is myelopathy. There is myelopathy, but what I mean to say is that in presence of such a lordotic canal, single level, the patient will not suddenly present with myelopathy symptoms. With a very big disc complex, it will be more like a radiculomyelopathy.
Yes, sir.
Right. Yeah. Go on.
We did a CT scan to see whether there is any bony prominence, and at the C3, C4 disc space, we found that there is a disc osteophyte complex which is going into the canal, and it is decreasing the canal space and causing the myelomalacic changes. So what would be the plan for the surgery? Since the patient has only anterior pathology, which is causing the compression and causing the myelopathy, we
First is why are you thinking in terms of surgery? Do all disc patients need a surgery? What is the natural history of disc disease?
so normally it's a 90% patient of the disc recovers, but since he has a long history, 3 months of loss of balance since walking, and on MRI we are seeing myelomalacic changes, he is more likely to be progressing towards myelopathic symptoms.
Right. Yeah.
So we did a anterior corpectomy with from C3.
Why Subhanshu, why is posterior an option for you? Can you just go back one slide? Why did you put up anterior and posterior over here? What made you think that this patient could probably need a posterior surgery?
No, so just for discussion.
So your options should have been whether in anterior approach, what are the things that you want to do now? Right?
Yeah, yes, sir.
So when you put a plan, it is but obvious that this patient needs an anterior approach because there's no calcification. It's a pure disc pathology.
Yes, sir.
Right? Now your option should be an anterior surgery. Anterior में क्या करेगा? Fuse करेगा, replace करेगा, आयुष को पूछेगा क्या करेगा? So disc replacement करेगा. Okay. Yeah.
So we went with corpectomy because there was a calcified disc between C3 and C4. We need to remove a good we need to give the patient a good decompression.
Right. Okay. Could you have got away with only a discectomy?
So the visibility while doing the surgery will be compromised because it is a bony.
So I'll tell you my opinion. I mean, the faculty. The issue in this case is, once you distract the anterior column by putting in a graft or a spacer of adequate size, you are giving a good decompression. Also you're restoring the lordosis. The cord is automatically falling behind. So unless you're 100% sure that is retrovertebral compression, a little bit of retrovertebral compression can be managed by giving lordosis and doing a good decompression. So your decompression is direct and also it adds to it by giving lordosis. You got me? Because the cord is moving away. So Ayush and Akhil, your thoughts on these?
100% for me, anterior and ACDF. I think you can get away with ACDF, and if you want, you can really remove that. There is just a osteophyte which is growing in. There are many ways to do it, and safest way is if you have a ultrasonic burr, you can really take it out, or maybe use a curette. But as Dr. Sandeep said rightly pointed out, just a decompression will distract and really take away. So a good cage anteriorly and just thinning out that osteophyte will do the job. Corpectomy for me is a bit on the higher side.
I also agree. I think ACDF would.
So Subhanshu, why does the faculty not disagree, not in favor of corpectomy over a discectomy. Any thoughts on that? You have done an excellent job, no doubt about it. But what could be the reason?
That the calcified part.
No, in this case, you're fusing one level extra, right?
Yes, sir.
If you do a discectomy, you're fusing one level. If you're doing a corpectomy, you're fusing two levels. So you're losing out on motion at the lower area for no fault of that particular level. But having said that, even this approach is quite rational because your primary aim is good decompression.
Yes, sir.
Right? Okay, fine.
Thank you, sir.
Sir, we have one more case which was prepared by Dr. Raj Sakrekar. Can we have that case presentation, or you want to wind up?
I'm okay with whatever. I mean, these guys want to go on, I can go on. Yeah, we can go on.
I think then let's have that case presentation by Dr.
Yeah.
Sakrekar.
Yeah.
Hello, sir. I will be sharing the last case.
Yeah, go on, Raj.
So, he was a 55 male, sir. He was 55 male. He came to us with the imbalance while walking. He was a diamond jeweler by profession, designer by profession. He had difficulty in fine movements. The finger grip weakness was there. When we examined, he walked with the myelopathic gait. Reflexes were exaggerated. Hoffman's was positive. Plantars were upgoing. Uric grading was 4, and modified Japanese scores were 12. These are the images of the patient. This is the MRI, CT, and the X-ray, dynamic X-rays of the patient. So, anyone want to come up with the plan, sir?
Ameya is there, Ameya, Subhanshu, because these are the only guys who can see over here. Subhanshu?
Yes, sir. Yes.
Yes, sir. So the patient is having a kyphotic cervical spine with an anterior compression pathology, which showing myelomalacic changes. I would like to go posterior first, followed by an anterior decompression, anterior surgery.
Why posterior?
So it is a localized kyphosis, not.
So, Subhanshu, if it's a localized kyphosis, you need to go anterior to correct the kyphosis, right? So, this thought process is very, very important. Just because it is kyphosis, you need not go posteriorly. In fact, kyphosis is something which allows you to go anteriorly and correct the kyphosis by giving good anterior decompression and reconstruction.
So it is a multi-level involvement. If we want to go anteriorly, we need to fuse at least 1, 2, 3 level, and more than 3 level, if it is there, then we need to go posterior.
Right. So in this case, if you follow the C2 and C3, if you follow the anterior CSF signal, which is anterior to the cord, it is present right up to C3, right? Inferior end plate. And it again starts at around C4, C6, right? So again, this is exaggerated because of the kyphosis. If you correct the kyphosis in this case, whether it is a single level or 2 level, I would preferably go with 2 level and put the column back in lordosis. You will get a good CSF flow anteriorly, and that will give you a good decompression. But having said that, anterior, posterior, both are justified. It is just a question of what ideally should be done to give maximum advantage to the patient in terms of neurological recovery and also not cause iatrogenic damage. Like if you're going from C3 down to C7 posteriorly, you are unnecessarily fusing C3, C4 and down to C6, C7, right?
Yes, sir.
That's the issue. So, Akhil, what is your thinking?
Sir, I'll go anterior for this. I was just saying, so there is no component of OPLL as such. We can get away with a corpectomy from the front and doing a anterior fusion, ACCF, for this. That would be my plan.
Right. Ayush?
So I think the whole problem is coming from the localized kyphosis. So for me, definitely ACDF. On the safer side, I will say 2 level, but I can tell you even with 1 level, you can get away with this very easily. The moment you correct that 3, 4, 5, where the signal channel, you get a good size case and correct the lordosis and take a post-operative MRI, you will surprise that all the compression you see anteriorly has completely gone. If a single level can do it, but if you want to be on the safer, maybe 2-level ACDF, nothing more than that.
Yeah, I think I would, to be on the safer side, I would go ahead with a 2-level corpectomy. If you look at the CT scan, you know, the C4 vertebral body posteriorly looks a little bit ossification, right, on the CT scan. So again, Ayush, the approach which Ayush said is absolutely justified, but to be on the safer side, I'll probably do a single level corpectomy, maybe a C4, and do 1-level discectomy. Even that is fine, sort of a hybrid anterior procedure. The whole idea is decompressing the cord well and restoring the lordosis.
So once we get that lordosis right, the whole thing will simply shift off. So we sort of have done CTs for these cases, and we have seen that you can get away, if you're going anterior, you can get away with very minimum compared to doing a bigger job posterior. That is where the debate lies.
Agree.
Yes, sir. So, sorry for the just one cut. The other cuts of the sagittal and the axial were there. The CSF shadow was maintained at other levels other than the C4-5 level. So, even AMGNC and SSFP all directing to the C4-5 level being the only pathological and not the rest of the levels. So, we went ahead with the single level ACDF 4-5. This is the intraoperative picture. This is the post-op X-ray. And patient recovered. The scores of the neuric grading improved by grade 1 or 2, and the MGO scores also improved, and patient doing well currently. Thank you.
Did we get a post-op MRI?
No, sir, not yet.
Not yet. Okay.
So Raj, this is an excellent procedure which has been done. The only thing which concerns me is that whether you achieved enough, at the lower level to give a good decal. And the second thing is that if you look at this implant, I would rather prefer a good cage, a good graft fashioned in lordosis and a plate, because the whole idea is again to create lordosis. And this single level standalone, I am not very sure whether they can actually help in recreating the lordosis.
Yes, sir. Actually, I have came across one of the papers which compared standalone cage with the cage and plate, and also with the graft. So all these articles were showing the results are equivocal. There is not statistical difference. So considering the less morbidity, the standalone cage was preferred by the many authors in the literature. So maybe as per the surgeon's experience, everyone can relate accordingly.
Agree. Yeah.
So
Thank you.
Get a post-op MRI, and I think you will see that you have done a good job. That is my belief. This is so you will be surprised when you go and even do a single level. The post-op MRI will surprise you, and we have got now almost more than 250 post-op MRIs, and there are few surprises when you have gone anterior, and that makes us go like even less if you do, and you are anterior, you'll get away with doing more because the whole alignment changes, and that really adds to things which you think you won't be able to do.
Yes, sir. Thank you. At the end, I'd like
Ayush, just one thing, just because we are on this forum and the correct message has to pass, nothing against it. The question is the probability, like pre-operatively, I mean, you have done all these cases and now you're retrospectively analyzing.
I agree with you.
Pre-operatively, it's very difficult to predict which way this patient is going to go. So it's always better to be on the safe side.
Yeah, I agree completely. I'm just talking what we have done and reviewed back. I'm even pre-operatively, I told I will go for 2-level. Although what he did, I agree to that.
Right.
Thank you, Dr. Raj. I would like to conclude the session by just giving a brief summary and the takeaway points. I'll just share my screen now. Is it visible to everybody?
Yes, sir.
Okay, all right. So once again, quickly, it is the most common cause of spinal cord dysfunction, that is the spondylotic myelopathy in adults. Primarily starts with gait imbalance, can cause significant reduced hand dexterity, sensory motor involvement, and functional status. Now, the deterioration can either be in a stepladder pattern or there can be a relentless progression. We routinely get dynamic X-rays, MRI. Important to also see the T1 weighted images to see if there is any hypointensity, because that would portend to poor prognosis. There is something called as diffuse tensor imaging. This is rapidly picking up. It is able to pick up the myelopathy much earlier than the MRI. Basically, this is an extension of its use, which was done in the brain. And there are some prognostic factors which have been associated with diffuse tensor imaging. So we'll be seeing a lot of literature on this in coming few years. Also, CT scan should be routinely done if one suspects OPLL to plan for whenever there is surgical intervention that is planned. Some special considerations. So if there is neurological injury, then intraoperative neuromonitoring plays a very important role. It has been found that preoperative SSCPs have a correlation to know the prognosis. Also, the transcranial motor evoked potential can guide us during the surgery. However, the distal TCMEPs may be impaired. Both together, that is the SSCPs and TCMEPs, they have a high specificity of a neurological injury to the extent of 96%. So I quite commonly use intraoperative neuromonitoring when I'm doing cervical myelopathy patients who have significant neurological compromise to start with. EMGs routinely are not very sensitive or specific. Anesthesia consideration is also important. So the anesthetist have to be told not to do excessive neck extension, because the ligamentum flavum can cause compression of the spinal cord. Fiber optic intubation should be routinely recommended for this. In some patients, we also do deep, the awake intubation in some patients. And as Dr. Ayush had previously mentioned, at least we have to maintain the maps of more than 80, though now probably 85, 90 is also not a bad value. This has already been considered, but broadly, the surgical approach depends upon the alignment, presence of OPLL. It also depends upon the presence of any axial neck pain and radicular symptoms. So where is the future direction? So the problem with cervical myelopathy is there are no randomized controlled trials to know whether operative or non-operative treatment can be given, because ethically no surgeon will like to do non-operative treatment in a patient who has significant neurological deficit. So we don't have any randomized controlled trials, and I don't think that this is going to change. At the neuromodulation level, as Dr. Ayush had mentioned, there is a role of riluzole, cerebrolysin, and now zonisamide, which is being extensively studied in rat models and would find some application going forward on this. So with this, I would like to conclude the takeaway points. I would have Dr. Sandeep Sonone sir to add anything more to this.
No, I think more or less we have covered everything. But I think we need to touch up on, we need to have OPLL as a separate topic, because it cannot be confused with cervical myelopathy. So maybe next time, whenever you guys plan it out, plan OPLL as a separate topic, because that's a different ballgame altogether. So overall, I think we have covered most of the things superficially. In depth, we can always go in and have more literature review later on. So thank you.
Thank you, everybody. I would really want to thank Dr. Sonone sir, Dr. Ayush, and the other faculty and all the fellows who have actively participated in this. With this, I would like to conclude this session. Thank you.